Friends, in this video we are going to see management of a soft cataract. Nuclear sclerosis in this cataract is about in grade 2. This is the main incision with a 2.8 mm steel keratome at mid-limbus. The incision includes some capillaries. The antechamber is filled up with 2% hydroxypropyl methyl cellulose, and methyl cellulose is applied over the corneal epithelium for better visibility. This is a sight port on the left side of the main incision, and now capsulorhexis is done with the help of this Utrata forceps. The capsular tag is guided anti-clockwise all around, and a fairly round rhexis is done. Diameter of this rhexis is about 5 mm. Hydrodissection is done with the help of BSS and this 27 gauge cannula. The nucleus is mobilized, and we see that the nucleus rotated well. Visco is again used to fill up the anterior chamber, and then this is the time to introduce the Phaco needle. The Phaco needle goes in with its bevel down. Some superficial cortical lens matter is removed. In this case, plan is to do direct chop after making a short trench up to the middle of the nucleus. So making a short trench going to deeper plane. Now I try to hold at the center and just engage the tip and hold and try to chop it, but the hold was not good because the cataract is soft, so I could not chop the nucleus. So what is to be done? Immediately the next plan is to make a trench along this path, go to a deeper plane. So next plan is to do stop and chop technique. Go to deeper plane, particularly at the center, and when it is sufficiently deep, use two instruments and divide the nucleus into two halves. Now try to chop it again. At this time the heminucleus comes out of the bag, and it becomes easy to chop into two pieces, and the two pieces are emulsified. We must tilt the piece, bring it out of the bag, and then apply ultrasonic energy. Here also we must hold it carefully, not at the lower part but at the upper part, or we may come out, inject some visco behind this piece and make this nuclear piece stand up like this. And then if we apply ultrasonic energy now at the apex of this piece, we ultrasonic energy here, we are not going to catch the posterior capsule. Moreover, visco is behind the piece, protecting the posterior capsule. Yes, it is done. Lot of cortex still remaining, so the next plan is to remove the cortex with the help of a coaxial irrigation aspiration device. This is the coaxial IA, and we can very quickly remove all the cortex with this device. Sometimes it becomes difficult to remove the subincisional cortex, but with practice we can remove the subincisional cortex also. And now is the time to implant an intraocular lens. This is hydroimplantation. The antechamber is kept formed by irrigation and the lens is implanted. This is a C cartridge, and we need not enlarge the main wound. And now the lens is dialed. There is a compression mark at the center of the optic, and within few minutes this compression mark will go off. The side port is closed by hydrating corneal stroma. And now a final lavage of the anterior chamber. At this time, a gentle stream of BSS is directed towards the corneal endothelium, and whatever visco sticks to the corneal endothelium is removed. Then the antechamber is formed very nicely and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Whenever you can't hold the nucleus, we can have another plan. We can do the case by stop and chop technique, making a deep trench along the path of the direct chop.